Maybe I'll start with a question while you guys are gathering your thoughts. And this is a question for Jordan, who's sitting to my left, who I have a tremendous amount of respect for. And the question is about Afib ablation and the fact that moving directly to an Afib ablation is now a class 2A recommendation. Is that correct?
If they don't want to take medications.
If they don't want to take medications. And the reason I ask this question is we take care of a lot of folks that come in with AF, and we have a lot of folks that get ablated, and more we're seeing folks that are cured of their atrial fibrillation but not cured of their exercise intolerance. And so my question is, do you think there is a subset of people that undergo Afib ablation that have enough substrate modification that their atrial conduit function is off, or something about their ability to then generate peak cardiac output is forever and indelibly screwed up?
I'm
sorry, I just had to ask it because this is such a complicated question.
Yeah, no, it is a really good one. Yeah, I definitely have patients like that. Some of it may be substrate. So I think some of these people do have a fair amount of either exercise-induced hypertension or other hypertension that is leading to some element of diastolic dysfunction that plays into it. And I think that might be for a fair number of people, the etiology. Otherwise, I don't know. Yeah. Why are some athletes getting this and some not? Is there something else about their genetics, about their environment? Is there some other cause for these people that is leading to some subclinical cardiomyopathy we don't know about, or whatever it is? I don't know.
Yeah, and I think the other thing to comment on here, and I think you did a great job presenting this with equipoise, which many EP docs don't do, and that is that there still really is a role for medical therapy in many of these folks. And we have a lot of individuals with AFib that are well maintained in sinus rhythm on class 1C agents for very, very long periods of time and feel really quite perfectly normal. So I think ablation has an important role in the kind of the overall treatment strategy, but it's not something that I've necessarily jumped on the bandwagon to go right after right away.
Yeah, and I agree with that. I mean, I think I treat them like I would anyone else, and I have the discussion of here's medications, here's ablation, here's the data, and it's up to you what you want to try and do and what your risk tolerance is and such. Dr. Rowe.
I enjoyed all three of your talks very much, but I want to pick on Jordan because I really enjoyed picking on Jordan.
Please understand that Rob used to be one of my mentors, and now I don't like him anymore.
So, fair enough. So there's a interesting parallel literature on GERD, exercise and GERD, and then GERD, especially among runners. There's some kind of interesting studies that convincingly show that as you run, you get more GERD. And then there's an association between GERD and atrial fibrillation. And recently there's been some connections between the two. I wonder how you think about GERD as, is it an important part of the pathophysiology of AFib in athletes? Or is it just kind of an interesting phenomenon and you just kind of dispel? That's question number one. Question number two is, do you think we have enough data in women to really conclude that there is no harm with extreme exercise? Because I do have a handful of high endurance, extreme athletes that are women that have atrial fibrillation who have no real reason why they should. And yeah, I think the studies on women are pretty small, and the criticism is that it wasn't a cohort that was exposed to extremes of exercise. I wonder what your thoughts are on that.
Yeah, how about I'm going to answer the first one, and then I'm going to actually, the second one, have all of us talk about. So the question of GERD, I think it's an interesting one. I don't know if we know enough about it yet. You have to presume some sort of vagal effect or vagal relationship of GERD. GERD with AFib, GERD and is there some differential effect with athletes related to that? I don't know if we have enough data yet, but I think it's an interesting question. And then the issue of women, I don't think we have enough data with women. I sort of put up there, this is what the initial data is showing, but I think anything related to exercise and AFib and women is still preliminary. I'd be interested in your guys' thoughts about the exercise and coronary disease.
Well, I'll say something about women and AFib, and that is I think it's worth stepping back and considering the natural history of female athletics. Most of the men we take care of with atrial fibrillation started exercising as high-level endurance athletes in the 80s and 90s. And at that time, if you look at the distribution of men and women that participated in those sports, it was 90% men and 10% females. At this point, we're much more into a 50-50 balance. And so there are lots more women at young ages who are starting to push hard, and we're now seeing over time that they're getting into their 40s and 50s. So I think, while there may be gender differences, I think we're going to end up seeing that it's probably not as clear a divide as we thought it was. Just a guess, though.
Yeah.
Yeah, I'm interested in your talk about like cardiomyopathy in athletes developing over time and arrhythmias developing over time. And you talked about stress points, like where the RV inserts, that sort of thing. And in one of the examples you gave was Harvard rowers, out there increasing their volume really significantly, which we see a lot of sports teams, like they come in, they do 2-a-days, they do all this stuff. And now we have this phenomenon of HIIT training where, we're throwing people into super high intensity workouts with not a lot of preconditioning. Do you feel like we're maybe getting into more complications with this sort of inappropriate training, this idea of inappropriate training where you're not periodizing, you're not increasing appropriately, and what the role that may be going forward in terms of like really teaching people how to increase their exercise going forward?
So maybe. What we don't really have, and the reason we don't have this is because it's not really possible yet, are the natural history, ideally prospective studies to look at the impact of the type of exercise you described. Very rapid escalation, high intensity intervals, particularly among younger people, and where that gets them several decades later. I think we need to do it. I think some of us are trying to do it, but until we have the outcomes data, I think it boils down to picking your opinion and sticking with it. Mike, you're a CrossFit guy. You want to talk about that?
So, like anything, if you don't prepare properly, you're going to have complications, including myocardial complications. High-intensity interval training is generally pretty safe if done under the appropriate supervision. There are cardiac rehab programs now that have shown safely that they can institute a high-intensity interval training in phase 2 cardiac rehab and be relatively safe. Smaller studies, purposely selected populations, but there is some data. Now that high-intensity interval training is a big, broad category, right? So high-intensity interval training that's done in kind of cardiac rehab is very structured, very short, brief bouts. If you want to talk kind of the other extreme of high-intensity interval training in CrossFit, that's a little different, or maybe a lot different. But they haven't really studied outcomes in that. Having personally been in that world, I'm not seeing a lot more complications in that population than I am in any other athletic population. Now, maybe they come more fit anyway. So it depends upon your perspective and how good of a facility you have.
Last question for the panel.
Hi, I'm a primary care sports medicine doctor in Denver for a Division II school. My question, it's a little bit tangential. It's going back to the shared medical decision making. When you're coming across these athletes and you're coming across these diagnoses where maybe in the past it would have been a little bit easier to reflect saying, you can't participate as a team physician. What are your thoughts on possibly having them sign some sort of acknowledgement form, something like that, from a medical legal standpoint, saying, the doctor thinks I'm higher risk, but given that circumstance, I still want to continue in case a worst case scenario thing occurs. Because we can document in our form, that we had this discussion and feel like, maybe it's in their best interest if they really do want to play, if it is oxygen for them to keep playing, but just having that extra paperwork to potentially protect us if need be. Thank you.
So that's always an interesting conversation to have. I'll start by saying I'm not a lawyer. In general, though, medically, legally speaking, those waivers don't hold up in a court of law. There have been cases in the medical literature and the legal literature where athletes have voluntarily said, I'll sign the waiver, and the school says no, and they've taken them to court, and the courts have sided on the side of the school. So whether they would hold up at all is up for debate. Obviously, any school lawyer is going to be involved with it up front, and they're going to make the decision probably anyway.
Just to build on that, though, all of the legal precedent to date is before the last edition of the Bethesda update, in which there was a clear standard of care delineated in that document around exclusion, right? The current new Bethesda has somewhere around 90 Class 2 recommendations, which means there's a lot of wiggle room in there. And so we don't have any legal precedent to help us understand how decision-making after that document is going to go. And what I will say is that many of the colleges and universities that reach out to us for second or third opinions in which we offer an opinion show interest in using waivers, and we've been very proactive in terms of helping them develop the wording around these waivers, because I do think not only is it good for the schools, it's good for the student athletes and the parents to actually have something in front of them that spells out the discussion we've had, and it helps in that digestion process. So I'm personally, although I agree with Mike, we have no idea what it will do in a court of law, personally a big believer in the use of these forms.